questions before you hear each extract. Extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll extracts. In each extract, a health professional is talking to a patient. For questions 1 to 12, complete the notes with information that you hear. Now, look at the notes. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Imagine being able to build anything just by thinking about it. Meet Base 44, a complete
Good morning, Doctor.
Good morning, Mr. Thompson. It's nice to see you again. How have you been since our last visit?
I'm doing okay overall, but I've still been having that wheezing, especially when I lie flat at night. And when I do a bit of walking on the treadmill, I get short of breath.
I'm sorry to hear that. Let's start with the wheezing. You mentioned lying flat. Does it ever wake you up from sleep?
Yes, I sometimes wake up gasping a bit. I've been using my albuterol inhaler, which helps a little, but it's not completely gone.
Understood. We'll want to keep monitoring how often you need that rescue inhaler at night. Now let's talk about your reflux. You mentioned heartburn?
Right, I get a burning feeling over my chest, mostly at night or after meals like pasta with tomato sauce, and when I have my morning coffee.
That sounds like classic GERD. We'll trial a proton pump inhibitor twice daily for several weeks and see if it helps both the heartburn and any reflux-induced wheezing. How about your blood sugar readings?
I check fasting, and it's between 95 and 115. 2 hours after meals, I'm around 140. Metformin gives me headaches at first, but now I tolerate it fine. I'm also on glipizide.
Those numbers are pretty reasonable. We'll recheck your A1C tomorrow with the labs and see if any adjustments are needed. Let's review your cholesterol. You've been taking simvastatin 20 milligrams, splitting to 10 milligrams daily?
Yes, my LDL is still above goal though.
Okay. After we get your repeat lipid panel tomorrow, fasting at 9 a.m., we'll consider increasing your simvastatin to 40 milligrams if your LDL remains over 100. Your blood pressure, any issues with the medications?
I ran out of my atenolol, the prescription expired. I'm still on nifedipine and HCTZ and haven't felt dizzy.
I'll refill the atenolol for you. We'll check your logs over the next month to ensure we're hitting your targets. If your LDL remains over 100, your blood pressure, any issues with the medications?
I ran out of my atenolol, the prescription expired. I'm still on nifedipine and HCTZ and haven't felt dizzy.
I'll refill the atenolol for you. We'll check your logs over the next month to ensure we're hitting your targets. One more thing. How are you doing with sexual function?
I have some mild erectile difficulty. Erections aren't firm enough or lasting, and sometimes I'm a bit premature.
Thank you for sharing that. Once we get your PSA and a prostate exam done tomorrow, if everything's clear, we can start you on Levitra, 2 pills twice a month with refills, and reassess how you're doing in our follow-up. I'd like to repeat a few labs and studies first thing tomorrow. Fasting lipid panel, A1C, PSA, and a urinalysis.
Sounds good. I'll come in before breakfast.
Great. We'll also schedule an ophthalmology exam for September 23rd to keep an eye on your diabetes, and please arrange for a podiatry visit soon.
Will do.
Lastly, your PFT shows a mild obstructive defect. Let's repeat that in 12 months unless your symptoms worsen sooner.
Okay.
Let's plan to meet again in 1 month to review your labs, adjust your statin if needed, start the reflux meds, discuss the ED treatment, and look at your blood pressure logs. Meanwhile, keep up with your home glucose checks, and let me know if anything changes.
Thank you, Doctor. I appreciate you taking the time.
You're welcome, Mr. Thompson. Take care, and I'll see you tomorrow for labs.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear.
With a local team based in Dubai, Forex.com gives you easy access to CFD markets across indices, commodities, local and global stocks.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good afternoon, Mr. Delgado. What brings you in today?
I've been dizzy and lightheaded, and I've had this persistent dry cough and headaches ever since I fell.
I'm sorry to hear that. Tell me more about the fall.
It was about 6 weeks ago. I slipped and hit my head and neck on the concrete.
That must have been painful. Since then, you've had dizziness when you move your head.
Yes, I feel a constant spinning sensation, especially when I turn my head, and my neck hurts all the time.
And how are you sleeping with the dizziness?
Not well. The cough wakes me up several times a night, 4 or 5 times, and I've been having headaches every day.
You mentioned a dry, hoarse cough lasting 4 months. Have you tried anything for it?
I tried Zantac, but it didn't help.
Understood. Any history of lung exposures?
I worked around asbestos years ago.
Thank you for sharing that. Have you noticed any worsening shortness of breath?
No, my breathing seems okay.
Let's talk about your seizures. When was your last one?
It was in July last year, and I ended up in the ER.
And how are you doing with your phenytoin?
I've been inconsistent. Sometimes I miss doses.
I see. Your last phenytoin level was low at 6. We need it closer to 10 to 20. We'll adjust that.
Okay.
How about your mood? You mentioned anxiety.
I've been hiding in room, having panic attacks. I have a psychiatry appointment on June 14th.
Good that you have that appointment. Let's make sure you have support until then. I'd like to review your blood pressure and diabetes too. Your BP is a bit elevated on lisinopril, and your fasting sugars are running 160 to 180. Post meals are 180 to 220.
Yes, they're higher than I'd like.
For your blood pressure cough, I suggest switching to losartan. For your diabetes, instead of pioglitazone, we can start glipizide. How does that sound?
That makes sense.
I'm going to increase your phenytoin to 330 in the morning. Schedule naproxen twice daily for your headaches and neck pain. For your blood pressure cough, I suggest switching to losartan. For your diabetes, instead of pioglitazone, we can start glipizide. How does that sound?
That makes sense.
I'm going to increase your phenytoin to 330 in the morning. Schedule naproxen twice daily for your headaches and neck pain, and reinstate duloxetine while we wait for the formulary approval.
Thank you.
We ordered a chest x-ray today given your asbestos history and cough. If that's abnormal, we'll get a chest CT. I'm also referring you to ENT for persistent hoarseness.
Sounds good.
I've administered your pneumococcal vaccine and placed orders for your annual hepatitis C monitoring, colonoscopy, and diabetes eye exam. We'll have you back in 4 weeks to check your phenytoin level, review how you're tolerating the new medications, and reassess your symptoms.
I appreciate it, Doctor.
You're welcome, Mr. Delgado. We'll also get you set up with physical therapy to help strengthen your neck and improve your balance. Let's work together to get you feeling better.
Thank you. I feel more hopeful.
I'm glad to hear that. Take care, and I'll see you soon.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
I just filed Incident 25 in the Risk Management portal. 3 dialysis circuits in Pod B clotted within 2 hours last night.
I know. The anti-coag pharmacy sent over that new heparin biosimilar because our usual stock is back-ordered, and the activated clotting times never went above 180 seconds.
Exactly. The patients are stable, but we used up every spare dialyzer cartridge on the ward by 3.
On top of that, the vascular access team is furious. Each catheter needed urokinase salvage, and we're down to our last 2 vials.
Biomedical engineering thinks the dialysis machine's pressure alarms masked the rising transmembrane pressures, so no one caught the sluggish flow early.
I've requested a lot release test on the biosimilar. Quality wants samples within the hour, or they'll quarantine the entire batch.
Do you think we should pivot back to regional citrate anticoagulation until supply stabilizes?
Possibly. But the nephrologists worry about calcium shifts with our liver failure patients. We'd need continuous ionized calcium monitoring.
I'll brief Dr. Chen at noon rounds and ask pharmacy to secure low molecular weight heparin as a bridge.
Good plan. Meanwhile, I'll draft an XBAR for evening shift so they're ready if another circuit starts clotting.
Now look at question 26.
Ticket 26 just pinged my phone. The new voice-activated infusion pumps are misinterpreting Cree commands and stopping mid-dose.
Yes, I heard a pump pause when a family member greeted the patient in Cree. The phone recognition thinks tiny C sounds out like cancel.
That's dangerous. These pumps deliver vasoactive drips, and a sudden stop could crash a patient's pressure.
Linguistics says the algorithm was only trained on English, French, and Spanish accents. Indigenous languages weren't even in the test set.
We could disable voice mode, but facilities already pulled the tactile keypads for infection control reasons.
IT can issue a patch tonight, but biomedical policy requires a 24-hour validation before bedside use.
So we're stuck with manual workarounds. 2 nurse verbal readbacks for every vocal command in the interim.
Yes, and we've posted a sign in each room. Use English voice commands only until further notice. It feels exclusionary, but safety has to come first right now.
Let's loop in the cultural liaison to craft a respectful explanation, and I'll log a service deviation so the vendor accelerates language updates.
Agreed. I'll also add a competency check for staff to recognize silent pump fails until the patch passes validation.
Now look at question 27.
I reviewed the new tele-ICU protocol draft this morning, and I'm concerned about the liability provisions for nurse practitioners when they manage ventilator settings remotely.
I saw that. The legal team insisted on adding more oversight. but that could delay interventions by up to 10 minutes if the intensivist isn't immediately available.
Precisely. 10 minutes in acute respiratory distress can be critical. We need a contingency that allows NPs to adjust PEEP under predefined criteria.
What if we embed an automated alert that flags any deviation beyond 2 centimeters of H2O, triggering a secondary call to the intensivist?
That could work, but the alert threshold must be dynamically adjusted based on patient compliance and minute ventilation trends.
Agreed. I'll collaborate with IT to develop an algorithm that integrates real-time spirometry data before issuing an override alert.
Also, we need to schedule a training session so NPs fully understand the algorithm's limits and documentation requirements.
I'll arrange a workshop next Thursday with our legal liaison and the ventilator manufacturer rep to ensure everyone is on the same page.
Now look at question 28.
We've successfully installed the Avatar surgical robot in OR3, but our biggest challenge remains credentialing residents for autonomous suturing. The residents want more hands-on time. Hospital policy restricts robot operation to board-certified surgeons until further validation. Perhaps we can pilot a proctoring program where a certified surgeon supervises 2 residents per procedure, with performance metrics logged. Yes, we could measure metrics like tissue handling time, error rate per suture throw, and force feedback anomalies. Those data points will justify expanding access. We should also align with the e-learning module so residents must score above 85% on simulation before live cases. I'll draft a curriculum that combines virtual reality simulation, score-based progression, and incremental autonomy under proctor review. Let's convene the surgical committee next Wednesday to finalize the credentialing pathway and present the data collection plan. I'll prepare the slide deck with preliminary simulation results and the proposed proctor schedule for approval.
Now look at question 29.
Have you had a chance to test the AR overlay alignment in OR3 this morning?
Yes, but the holographic vascular mapping is consistently offset by 2 millimeters when we toggle to low light mode.
That margin could lead to serious misplacements during neurosurgical procedures. I think we need to recalibrate the depth sensors.
Agreed. I've contacted the vendor to push a firmware update, but they're backlogged. As an interim, we can manually adjust the Z-axis scaling for each case.
Manual adjustments will slow turnover time, but patient safety takes priority. Let's draft a protocol for the surgical techs tonight.
I'll coordinate a quick training session and document the recalibration steps in the procedure manual.
Good. Let's reconvene tomorrow at 700 to review initial feedback from the morning cases.
There's one thing the best communicators always do, but most never try. Yes.
Now look at question 30.
Our IVG inventory just dropped to 6 vials left after last night's infusion cycle.
We can't compromise the immunocompromised cohort. They need at least 1 gram per dose.
Given the national shortage, do we defer the moderate-risk patients and prioritize the high-risk ones?
That's the only ethical framework. I'll stratify the roster by infection risk score and notify the oncology team.
Also, let's explore compounding subcutaneous immunoglobulin for the low-weight pediatric unit. They can maintain trough levels longer.
I'll check with pharmacy compounding capacity and update you by noon.
Perfect. Meanwhile, can you draft an alert for procurement to bid on emergency allocation from the regional network?
On it. I'll also flag this for the next formulary committee meeting.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.